Welcome back, everyone. You are enjoying another episode of Fast Facts Pharmacology Edition, brought to you by a Tale of Two Hygienists in partnership with Elevate Oral Care. And now, please welcome your host, Tom Viola.
Hi, I'm Tom Viola, a certified pharmacist, dental educator, and author. Stick with me, and I promise to make the next few minutes the best pharmacology learning experience you've ever had. Hi everybody, Tom Viola here with another Fast Facts Pharmacology Edition, this one about cardiovascular pharmacology, but we're switching gears to coronary artery disease. Now, we know that coronary artery disease is caused by atherosclerosis of the coronary arteries, but we know that the ramifications really result from a combination of the hyperlipidemia and hypertension. We know ultimately that the oxygen demand of the myocardium is increased, but the supply of blood to the myocardium is decreased. Now, when the oxygen demand exceeds the oxygen supply, that results in what? Angina pectoris, right? Which can be pain, not necessarily in the chest and the left arm, but also places like the neck, the back, and even the lower jaw. What causes angina? Physical exertion, emotional stress, sometimes nothing at all. But we do know that if the demand consistently outstrips the supply, that's going to lead to where the myocardial tissue becomes permanently deprived of oxygen, and that can lead to necrosis, myocardial infarction. We don't want any of that because that can lead to things like arrhythmias and death. So, the treatment of coronary artery disease really involves what? Increasing the supply by increasing the coronary artery flow and decreasing the demand. Okay, but how? Well, nitrates, right? Pop open those blood vessels, and beta blockers to reduce the oxygen demand. But don't forget, we still have to deal with what caused it. So that would mean what? Anti-hyperlipidemic agents to lower the cholesterol formation. And these folks are subject to clots. So we've got to make sure we use anti-thromboembolic agents wisely here to make sure that we're preventing the formation of clots and ultimately problems like pulmonary embolism and stroke, and of course myocardial infarction, and even deep vein thrombosis. Okay, so if you're going to blow open those blood vessels, you better use nitrates, right? Sublingual nitroglycerin tablets, translingual spray. Again, they're great for treating angina, but they're also great for causing headaches. Remember that any of these medications can cause orthostatic hypotension. And one thing we must make sure is that whatever we tell our patients to bring with them, like in this case, bring your nitrate, whether it's the sublingual tablets or the spray, make sure it's in date and that it's actually going to work when we need it to. As far as cholesterol, well, it's all about the statins, atorvastatin, simvastatin, Lipitor, and Zocor, respectively, which inhibit our ability to make cholesterol. I mean, that's what we do. We make cholesterol for our muscles. But too much cholesterol, because we eat it and we make it, means that it can collect on the inside of our blood vessels. So we're going to make sure that we shut down our formation of cholesterol. But since we need cholesterol for our muscles, that means if you take away your ability to make cholesterol, you're likely to get what? Muscle pain, which is the chief side effect that many people complain about, in addition to things like anterograde amnesia. Remember that the statins are great for lowering those LDLs, which we consider problematic in producing plaque, but at the same time, they can interact with things like diflucan, fluconazole, which we use in dentistry to treat candidiasis, and even things like grapefruit juice and pomegranate juice. But what about those pesky anti-thromboembolic agents? Oh yeah, we talked about them already. We're trying to deal with hypercoagulation here, the formation of clots inside normal blood vessels. Well, there's two kinds, antiplatelet agents like aspirin and Plavix, which are great for reducing risk in patients who are otherwise risky. But remember, they do increase the risk of bleeding, especially since we use things like antibiotics in dentistry, which can reduce the formation of vitamin K, and NSAIDs, which have an antiplatelet effect all of their own. So again, we're going to ask, right? Take a partner. We're going to find out if the benefit of stopping the antiplatelet agent outweighs the risk of stopping the antiplatelet agent and causing perhaps a clot. That depends on the procedure and whether or not a consult is warranted. What about anticoagulants? Well, we've got things like Coumadin, which is highly dependent on vitamin K. So Coumadin inhibits the synthesis of vitamin K-dependent clotting factors. Good, in a way, because that's a great way to shut down your coagulation. Bad, because if you shut down coagulation too much, you're likely to bleed significantly. So, of course, we have a test, an INR, a blood test to determine where we are with the drug. And since it's so dependent on vitamin K, we know we can reverse Coumadin with vitamin K. But do we tell our patient to stop taking it? Well, again, we increase the risk of bleeding because we use NSAIDs and we use antibiotics. But ultimately, it's going to depend on the procedure and whether or not a consult is required. What about those other new anticoagulants like Pradaxa? Pradaxa was one of the first. It inhibits factor 2A, therefore no INR test is required, but it does need its own reversal agent, Praxbi. One more time, we increase the risk with things like NSAIDs and antibiotics. And again, we're going to have to find out if the procedure warrants discontinuing Pradaxa and increasing the risk of thrombosis. And as far as the even newer anticoagulants like Xarelto, Eliquis, and Cerveza, one of my favorites, what about Xarelto, Eliquis, and Cerveza? Well, they inhibit factor 10A. Therefore, they require their own reversal agent, Indexa. And the INR test really isn't necessary, again, because it's not going to be effective. Do we run the risk of bleeding? Always, because we use NSAIDs and antibiotics in dentistry. But do we stop these agents when we're coming up to a dental procedure? Again, it's going to depend on the procedure, depend on the need for a consult, and again, ultimately, does the benefit of stopping the anticoagulant and reducing the risk of bleeding outweigh the risk of the formation of thrombosis in that patient? So, my friends, until next time, thank you so much for staying with me through cardiovascular pharmacology. Look forward to seeing you again soon. Be well. Oh, and one more thing. If you want to hear more from me, be sure to follow me on Instagram, Facebook, or visit my website at www.tomviola.com.
Thank you for listening to another episode of Fast Facts Pharmacology Edition, brought to you in part by Elevate Oral Care, creators of the innovative and proven prevention-focused oral care products from Advantage Arrest Silver Diamine Fluoride to Fluoramax Sodium Fluoride Varnish. Learn more by visiting www.elevateoralcare.com and schedule your free CE staff meeting today. We'll see you next time for another Fast Facts.